You were talking earlier, I heard a number, 29 minutes. And the numbers I heard from you guys earlier were much smaller than that. 29 minutes sounds big to me, yes?
I would have given it 20 minutes.
Yeah, 20 minutes
I think you said a little less, but 20 minutes kind of, so 29 minutes is not that far off. And also has to depend on where the patients start out from. You know, how little are they sleeping at night? How severe is the sleep problem? I think Nicole's point is very good. You know, that this is, so far, it's a poster, and you know, maybe it is something that's going to turn out to be a wonderful option for these patients. You know, in theory, it doesn't have the gait disorder. In theory, we wouldn't necessarily see as much of the cognitive impact. But it sort of remains to be seen in these larger scale studies.
Are there other studies out there working on this right now?
For this particular agent?
Or any agent, but suvorexant in specific, do you know of any more?
I think with this, the newest agent to market, I mean, there's other things in different clinical trial stages, but I think for something that's on the market looking at certain patient populations, I'm not aware of any.
Are there, with the inclusion, but other drugs as well, this is a group of people in whom better sleep would really be nice.
And usually my sense is that most of the studies wind up coming up with all the negative parts. Why the drugs should not be used in the elderly, particularly the elderly demented patient population. So there's lots of data about all the bad things about these drugs, but it's not like there's a whole amount of data showing the drugs that can help without having any side effects.
And to get to that point, I want to follow up on that because I think what we stated at the beginning is showing that improvement in quality and function and burden on the caregiver. And I think these are things that we need to look at studies, especially when we're caring for an older adult, that might be different than the measurements that we're typically using in these studies. So, you know, my hope for the future as we design more clinical trials is to look at meaningful measures. And I think what matters to older adults isn't necessarily these minutes, but it's like that next day and the quality of life. And I think that would be an impactful study to look at as well.
The minutes are a metric, right? Which is trying to get at what you were getting at, which is that you feel better, you don't feel better, the next day is good or the next day is not so good. Maybe the minutes are simply an avatar for that.
An avatar in the sense of
mirroring
being a way to measure it.
Yeah.
If you have 29 minutes, that's good in terms of quality of life during the day and an impact on the caregiver. Maybe that might turn out to be the case. But that hasn't been demonstrated. You know, I think that you know, we're still stuck. The newer the medication, the less evidence gets to stack up against it. So in the case of the suvorexant, it's the new guy on the block, so there's less things going against it now. I think Carl poured at the point that, you know, these Z drugs were thought to be wonderful drugs, so safe for many, many, many years. And now there are these questions. Every year it seems like the FDA comes out with greater and greater questions for us.
I think this is one area where the quality of life, you know, is very important. You hear a lot of times people saying, we don't really care about quality of life, just show us the hard clinical endpoints. Well, I think this is really the opposite. Because I can foresee situations where somebody may have 29 more minutes of sleep objectively, but they still feel crappy, and vice versa. They may not change at all in the number of minutes extra they get of sleep, but they feel better. Which is more important? I would argue that it's the quality of life.
So this goes back to what I was asking. Maybe minutes aren't a bad avatar.
I think the example comes up with that I see a lot of. You mentioned trazodone is a very commonly used medication, and it's very common. I'll see somebody who's been started on the trazodone for their sleep problem by their primary care doctor, and they were so obsessed about their sleep and how bad it was for them and so forth. So they come in and I ask, well, you're on this trazodone, you know, how's it working for you? And they say, oh, it's great. I sleep through the night. And I said, well, before you started taking the trazodone, how'd you feel the next morning? And they said, terrible. Well, now you're taking the trazodone, you're sleeping all this. How do you feel the next morning? They said, oh, terrible. Because now they were probably dealing with the hangover effect from the medication. But because they were so focused that it was the minutes of sleep that it got them off track, I think, of what the goal is. I try to point out to them, why take the medicine? There's no benefit the next day.
And what do they say when you say that?
Oh, but patients come, they get in certain grooves, and part of being the clinician is to try to educate them about that, to point it out to them, and I think that they oftentimes will take the lead of the physician in terms of deciding, yes, you're right, it is the number of minutes that's the key.
Well, what I'm hearing again is that this is a field that's, I don't mean this word as a pejorative, it's really fuzzy. Because if you look for an objective number like minutes, you're telling me maybe the minutes aren't so important. Maybe it's whether you're feeling better or not in the morning. And maybe that's not your sleep at all. And maybe we're treating the wrong thing if we're going after minutes and we want to make you feel better for some other reason. What is a clinician to do with all of this? How do you manage your day?
They should do a fellowship in sleep medicine. We're recruiting right
Wait
now.
a minute. You are the dons of sleep medicine, and you're fuzzy. What if I did my fellowship with you? Would I come out clearer than you guys?
Well, I think it sounds clearer and the problem is this: is that not all insomniacs are the same. And I think that if you want sort of a clear-cut paradigm for this, is you're a surgeon.
I'm
right?
a physicist.
You just want to see where the lines are that and most patients, there are many things going on at the same time, and you have to factor all of those in, and that's why it's so complicated, and that's why it's so hard to study, because you can look at one piece of this. You could look at the degree of anxiety, look at the degree of pain, but in fact, in the end, patients have a couple of those. Maybe have two or three or four of those.
My respect for you is just mounting by the moment, because you're dealing with a difficult problem with multiple causes in elderly patients who have multiple comorbidities, and you're managing to make them feel better. That's tough, guys. Nice job. Well said. I can't do that. I want something simple. You've got a bug. I'm going to give you an antibiotic. See you tomorrow. In the meantime, you're paying for all of this.
But Peter, could I also say something?
Yeah,
We started the program by saying that insomnia is a subjective dissatisfaction with sleep.
Right.
And you asked me, is it subjective? And I said, yes, it's all a subjective disorder, defined subjectively. So it's not the sleep quantity that defines insomnia, it's the dissatisfaction with sleep. And if you can improve the patient's level of satisfaction with their sleep, I think you've done a lot to help them with insomnia.
And the buzzword for that is patient-reported outcomes, PRO.
But what I've also heard is you've got to recognize that sometimes it's not the sleep. Sometimes they come to you complaining they can't sleep, and they want to feel better by making their sleep better. And you've got to parse out whether it's the sleep or something else, and that's tough.
Right, such as their sense of well-being during the day.
Right. And then you got to have him pay for everything. So they come to you, and they say, please pay. And we want to do this. Do you go and say, you got to do step therapy or not? It depends on, I guess, the plan, right?
It depends on the plan. It depends on the cost of the drugs, if we're talking about drugs.
Right.
It depends on a lot of things.
Now, there's something I heard called niche contracting. What the heck is that?
I saw that in the outline, and I don't know what that means. I don't do contracting.
I'm so glad somebody else is
But
ignorant.
I don't know what that means either, niche contracting. Do you know?
Do you know anything about this? Or is it simply that you're going to pick specific groups, and those are the groups that you think will do better with specific therapies? Maybe that's what it is.
I don't know.
But do you have silos of people that look like they're going to do better on drug A or drug B or drug C?
Well, that's the nirvana. That's what we wish we always had, is segregating groups of patients so that we can, whether it's treating cancer or treating insomnia, we want to know which patients respond to which drugs. But we usually don't get that.